Sir, omphalocele is an abdominal wall defect where the abdominal contents herniate through an extra embryonal part of the umbilical cord, which has a covering sac. So it could be a minor defect and also a major defect, which can have the liver and also associated with other cardiac defects and other abdominal wall defects like bladder exostrophy. So usually it is in semi-urgent surgery unless the sac is ruptured. It can be a single stage surgery and a multiple stage surgery where the reduction of bowel closure occurs at a single stage, and sometimes it requires the formation of celastic pouch and gradual reduction of abdominal contents into the abdomen to prevent the abdominal compartment syndrome and the respiratory compromise and the closure of defect later. The anesthetic consideration in a 3-day-old newborn with omphalocele or a difficult intubation because it is a neonate, and also sometimes it is associated with other facial anomalies like macroglossia in case of Beckwith-Wiedemann syndrome and retrognathia or micrognathia. Difficult IV line, a neonate on top of it dehydration, increased risk of hypothermia because of large head, increased surface area and exposed bowel contents, increased risk of hypoxia and apnea, abdominal compartment syndrome where the contents are reduced in a single stage procedure, along with the cardiopulmonary compromise, which results in reduced perfusion to the kidney, liver, bowel, and the skin, resulting in renal impairment, hepatic impairment, skin necrosis, and gut necrosis. And there will be a lot of fluid shift and heat and fluid loss because of the exposed bowel wall. So fluid and electrolyte disturbances, post-op pneumonia, and the drugs to be titrated because of immature kidney, liver, and immature neuronal system in a newborn. Preoperative assessment includes a detailed perinatal history, including the gestational age, weight of the baby, birth history, presenting complaints, whether the baby received vitamin K or not, whether it is a preterm baby or a term baby, the mode of delivery, a feeding history, bladder and bowel habits, and history of any comorbids in the mother, especially diabetes, which results in frequent hypoglycemia in the newborn. Airway assessment, we have to look for any other facial abnormalities, large tongue, small chin, and sometimes babies may be electively intubated where we expect a large fluid loss and with the maximal abdominal defect. In that case, we have to check for the size of the ET tube and we have to check for the position of the ET tube and the Riles tube. Respiratory assessment, if it is a major defect, so usually the baby will present with a scaphoid abdomen and with a small thorax. So we have to look for the respiratory compromise, including respiratory rate, pattern of breathing, increased work of breathing, use of accessory muscles, nasal flaring, tachypnea and tachycardia, and we have to measure preoperative oxygen saturation. And if the baby is on the mechanical ventilator, we have to note the ventilator parameters. Cardiovascular assessment. In case of a ruptured omphalocele, there will be a fluid shift and the baby will be prone for dehydration and shock. So we have to assess the hydration of the baby by looking into the skin turgor, skin perfusion, capillary refill time, heart rate, urine output, fontanelles, and blood gases if available. Fluid resuscitation may be required and it should be adequate preoperatively. We should look for signs of other cardiac anomalies like abnormal pulses where there is pulse deficit and absence of femoral pulse in case of coarctation of aorta. And we have to look for central cyanosis. We have to look for poor feeding, poor perfusion, etc. And investigations includes complete blood count. We have to do blood grouping and cross matching, arterial blood gas analysis, urine routine, renal function test and serum electrolytes. And in chest X-ray, we have to look for cardiomegaly, hepatomegaly, if there is any signs of aspiration. And we have to note the position of ET tube and the nasogastric tube. Echo and cardiologist opinion regarding any cardiac defects. renal ultrasound if the baby presented with any syndromes, head imaging to rule out intracranial hemorrhage if the baby is a preterm baby. Pre-anesthetic management, we should ensure that the baby has adequate nil by mouth, and antibiotic prophylaxis should be initiated preoperatively. Bowel should be decompressed preoperatively with the nasogastric tube, and the baby should be adequately resuscitated before induction. Since it is a 3-day-old newborn, baby doesn't require any sedation and pre-medication. We have to pre-medicate it with atropine 20 mg per kg prior to induction. Operation theatre should be warmed to 25 to 26 degrees Celsius, and we have to prepare for active warming devices like active warming mattress and fluid warming kits. Difficult airway cot and equipment should be kept ready. Tube of sizes 3 and 3.5 if it is a term baby, and 2.5 if it is a preterm baby. Straight bed laryngoscopes like Miller blade should be kept ready, and the pediatric circuits. We have to make sure that all the drugs were drawn up in appropriate to the baby's weight, and a burette should be used for IV fluids. Baby should be kept and always transferred in a warmed incubator and fully covered to prevent hypothermia. After entering the OT, we should apply the monitors like ECG, blood pressure, and saturation. Invasive monitoring usually doesn't require, but a CVP line, which will be useful in the post-op period to provide TPN, it can be obtained. So we have to pre-oxygenate with 100% oxygen. We have to aspirate the NG tube to decompress the stomach. We have to implement a modified rapid sequence induction with sevoflurane or thiopentin 4 mg per kg, and a muscle relaxant atracurium, which is appropriate for the baby since it doesn't require any renal or hepatic function to be metabolized. An ET tube needs to be positioned and secured at a proper position. And is maintained with oxygen, air, nitrous to be avoided to avoid further bowel distension, and maintained with a muscle relaxant. And analgesia could be provided with fentanyl at a dose of 1 to 2 mg per kg, or if post-op ventilation is planned, morphine can be chosen at a dose of 0.01 to 0.1 mg per kg. Epidural or caudal catheter can be placed, but preferably a single shot caudal with 0.25% bupivacaine at 1 ml per kg can be given. So we have to prevent hypothermia and temperature to be monitored. Intraoperatively, fluid loss is managed with isotonic fluids. If there is blood loss over 10% blood volume, or we have to maintain the hemoglobin 10 to 12 grams per deciliter, PRBC should be transfused at a volume of 4 ml per kg, platelets and FFPs at 10 ml per kg, and cryoprecipitate at 5 ml per kg. Termination of anesthesia. Babies with a small defect usually can breathe spontaneously, and there will be decreased chance of respiratory compromise in the post-operative period. So we can extubate the child after reversing with neostigmine 0.05 mg per kg and glycopyrrolate 10 mg per kg. Once the baby is fully awake with a regular spontaneous breathing and vigorous muscles. But majority of the baby require post-op ventilation in view of increased intra-abdominal pressure and compromised respiratory function. So post-operatively, we have to continue mechanical ventilation and sedation with morphine 10 to 20 mg per kg per hour and atracurium infusion of 0.5 mg per kg per hour. And sometimes the baby requires muscle relaxation in order to prevent intra-abdominal compartment syndrome. We have to check and assess the fluid balance, and we have to replace the fluids with 0.9% saline along with dextrose to prevent hypoglycemia. And post-op analgesia can be provided with the morphine and fentanyl infusion, and additionally 10 mg per kg paracetamol 6-hourly intravenously or per rectal. Temperature should be monitored and maintained post-operatively. And since prolonged ileus is expected, usually for the next 3 to 4 weeks, the baby should be provided with total parenteral nutrition post-operatively. And antibiotics should be continued until the celastic pouch is removed and the final defect is closed. That's all, sir. Thank you, sir.
I think you have got a little confused with gastricitis as well as omphalocele. Combine your answer looks like you are thinking about both the conditions. Okay? But the question when it specifically says omphalocele, it is arising mostly as a defect from the umbilical region, midline swelling.
Yes, sir.
And it doesn't cause, as you rightly said, it is a semi-urgent surgery. Whereas
Yes,
the gastroschisis, the bowel which is extruded has no covering. So there is a more chance of the child becoming sick more because of the rapid loss of fluid.
yes, sir.
And again, as I said for Sanjuta, all these case scenario cases, you always classify the challenges. Here, this is a challenge of a neonatal anesthesia compared to Sanjuta's case where it is a infant, little grown-up child of 9 months. Here it is a neonate. What is the definition of a neonate? When will you call a child as a neonate?
Sir, after up till 1 week, it is early neonate, and from 7 days to 30 days, it is late neonate.
Totally, what is the duration to call a baby as a neonate?
3 days after the baby is born.
28 days after birth.
Okay.
So 28 days of birth or gestational age. So up to 44 weeks of gestation, it is called a neonate. Okay, so 3-day-old means definitely it's a neonate. So
Yes,
you
sir.
must elaborate and enumerate all the challenges of neonatal anesthesia first. Okay?
Okay.
Like the first and foremost is they are very prone for hypothermia.
Yes, sir.
The second thing is their airway is more difficult to manage compared to an older child. Then their
Yes.
cardiovascular system, the myocardium is non-compliant and they are rate dependent for cardiac output. And their respiratory mechanics are they go for frequent desaturation and breath holding is more common in the neonate. And the apnea of prematurity, if they are born prematurely, the post-op is very, very common. And their liver and renal functions are not matured. They all mature only after 6 months of age. So all the drugs have to be titrated and given carefully. And similarly, fluid balance also should be maintained properly. Airway management, you have to select the appropriate size tube and the length of the tube is very, very important. What is Toshen's rule? Have you heard of that? TOCHEN, Toshen's rule.
No, sir.
Toshen's 789 rule. Anyone? Usha?
No, sir.
Hiranmayi?
No, sir.
Right. So first you have to enumerate all those things and then mention about. And the omphalocele, can it be done at the age of 3 months, 3 years or 4 years?
No, sir.
No.
If it is a small defect,
Ah.
we can manage it conservatively.
How? What is the conservative management? Just leave it like that with the bulge all the time?
So they'll reduce the abdominal contents into the abdominal cavity and they will close the defect later, at the later stage.
But still, it is not the skin which is closing it, isn't it?
Yes, sir.
When you make the skin grow over the bulging part without even reducing it?
Epithelialization. There is
Epithelialization. How do you cause the epithelialization? By applying silver sulfur dioxide. Okay? So you can, or betadine, you can put that over that exposed part, and over a period of time it will epithelialize and the skin will grow over there. And you can treat it as an umbilical hernia later on. Okay? So that also is being done. So omphalocele compared to gastroschisis is not that riskier a procedure as you have described, like so many words about fluid balance, CVP line, intra-arterial line. All those things are majority of the times not required for this particular surgery. Okay.
Okay, sir.
So the first half is about neonatal anesthesia. Second part of it will be challenges in omphalocele. And the main thing you have to mention is all these congenital defects are all associated with other anomalies. So you have to rule out any cardiac, venovertebral, and other congenital anomalies in these patients before you take them up, and then manage them as you do for a normal neonatal procedure coming for an intra-abdominal surgery. Okay, so with that thing, I will just share my